Good evening, everyone. Tonight we're going to do another Ask Me Anything. Start off with a little bit of a show and tell. I've been playing around with some new toys. So this is the blood pressure cup I normally use at home. This is the Omron Evolve. Still a great cup. Like it a lot. All the data stores on the device and then Bluetooth to your app on your phone, and you can share it with my office or your other doctors if needed. But I got this device last week. It's called the Connect QT. It literally just came to the market last week. I pre-ordered it when I was at the American Academy of Anti-Aging Medicine event in December. I knew about its arrival because I have its big brother, the AtCore device in my office at Apollo Cardiology. That device measures not only your brachial blood pressure, but also estimates your central aortic blood pressure. And that central aortic blood pressure is your true blood pressure, because that's the blood pressure that your heart, brain, kidneys, and all your vital organs actually sense. So it comes with a nice bicep cuff. Takes the general, your normal brachial pressure, but give you a little bit of way that I would recommend doing it is generally do it first thing in the morning. You may need to do it other times of the day depending on what your doctor asks you to do, but generally start with first thing in the morning before you have any caffeine or anything in your system or exercise. You want to be resting for 5 minutes. You want your feet flat on the ground. You want your back supported in a chair, and you want your heart at heart level. You want to have a bicep cuff. You do not want to be using a wrist cuff. Those are highly inaccurate in the greatest majority of cases. So rest 5 minutes, take the pressure, record the measurement. This device then pauses, and then it inflates again, and then it's measuring essentially how stiff your arteries are, which then can help calculate what your central aortic blood pressure is. So when I was an invasive cardiologist, I would put catheters in your aorta and take those measurements. Since most people don't want tubes put on them just to measure the blood pressure, this is the only way a person at home could do this test at this time. Again, it's called the Connect QT. It's made by a company called Cardi. I'm not quite sure that their availability. I had ordered in December and just showed up last week. So I'll do a little bit more of a show and tell on my YouTube channel at some point. That's where more of the long form content is going to be housed. But wanted to share that first before jumping into the Ask Me Anything. So we'll fire away tonight. First question. Would you take a statin if you had no cardiovascular events, but a calcium score of 70 and you're only 43 years old? No symptoms. Symptoms don't matter for this question. Having a positive calcium score at that age is a very high risk finding. You're going to be likely into the 90th percentile, where 90% of your people of your age should still have a score of 0 or lower than what you have. So statins are tools that help reduce cardiovascular events. That being said, they do come with some side effects in some individuals, mostly muscle symptoms. So it may not be the right tool, but I often talk about 3 big levers. You got to keep nitric oxide high and the glycocalyx healthy. That's the first layer. Second is keep oxidative stress and inflammation low. That's the second layer. And the third is then keep the ApoB containing lipoproteins at goal. Generally with a calcium score above 0, you'd like your ApoB under 70 using any means possible of lifestyle supplements if they work for you, or medications. All right, best way for an 85-year-old to improve circulation in the legs. Bad veins, mostly sedentary. So it depends if you're saying the circulation is a venous issue or an arterial issue. If it's arterial and you have peripheral arterial disease, supervised exercise is probably the best way. If it's venous, it may be more of a conservative approach where compression stockings are first-line therapy to compress the veins that have their valves that are basically leaky. Exercise can help as well as your muscles are contracting. It can pump the blood through those leaky veins. Grounding would be a good thing, and then also sunlight. Sunlight improves the venous tension. So light on your legs, grounding on your legs would be a starting point, and compression stockings. Next question tonight. Atherosclerotic cardiovascular disease, elevated ApoB, looks like a APO4 allele, low desmosterol, statin, dementia risk. So if desmosterol is already low, I probably would not recommend high-dose statins. Doesn't mean that you can't use them at all, but you do want to be mindful that more likely to have side effects if testosterone is low and you have an ApoE4 allele. If you can't tolerate it or prefer not to take that risk, then you would want to use ezetimibe, a PCSK9 inhibitor, or Nexletol to get you to your ApoB goals. The risk of atherosclerosis and dementia are tied to your ApoB concentration. So statins don't cause dementia per se. They may cause brain fog in some people, but they may actually reduce the risk factors that drive dementia. So it is a little bit of a complicated story. So it's not a slam dunk that you have to take a statin or you're not going to be able to tolerate it, but you want to talk to somebody who knows the questions that you're asked and can talk about risk benefits for you. Does a diet higher in saturated fat, especially dairy, reduce nitric oxide production? Should not have a direct effect. Nitric oxide is produced through different pathways. Exercise is probably the number one way, as blood flows across the glycocalyx, which is the gel coat that lines your arteries, and then the underlying endothelium releases nitric oxide. Nitrate reducing bacteria in your saliva can break down nitrates that are found in green leafy vegetables and beets. And then my favorite one is UVA. When that wavelength of sunlight hits your skin, it liberates nitric oxide from your surfaces. Saturated fat should not have an issue for most people, but if it causes significant dyslipidemia and you have significant oxidized LDL because of that, that may reduce the glycocalyx's integrity and then lower nitric oxide, but that's a very circuitous route. By itself, saturated fat should not have any effect on nitric oxide as far as I'm aware. What do I make of a hsCRP level of 15? I would first want to repeat that to see if it's truly that high. hsCRP should be less than 1. It'll be elevated in the setting of infections, autoimmune conditions, cancers, a musculoskeletal injury, recent surgery. So it just means your immune system was turned on. Then it's the job of the doctors working with you to find the root cause of what's driving it. But first repeat it. I've seen hsCRPs, be 30, 40, 50 within a day of being, sick with some type of infection. And it may take, a few weeks to drop back down to 1. So you want to trend it. So repeat it. All right. Well, that one didn't pop up on the screen for whatever reason. All right. Is it true that no lifestyle choices, diet or exercise, can positively impact Lp(a)? Indirectly, it does not have an effect on Lpa lowering. Lpa is genetically determined what levels you will have. 20% of the population produces higher levels, and they're more atherogenic particles. If you have significant oxidative stress and inflammation, which can be mitigated by good lifestyle interventions, the inflammation drives higher levels of Lpa, so you technically can lower Lpa if you lower inflammation with lifestyle choices. And it's also beneficial to do those lifestyle interventions to reduce your risk of insulin resistance, reduce your risk of certain cancers, reduce your risk of Alzheimer's. So even if it doesn't lower Lpa directly, the lifestyle interventions are still worthwhile. The person's asking, I hear and read a lot about the body having inflammation. Can I explain what that means? So think of inflammation as, too many protons, not enough electrons. That's the quantum biology reason. So you can improve your electron flow with grounding, improve your electron flow with sunlight exposure on your surfaces, your skin. But the colloquial way to say it is inflammation is fire. Do you have significant arthritis? Do you have a issue with your gut? Do you have, celiac disease? You're sensitive to gluten and it's causing inflammation in your system. Inflammation is good when you have an infection. Inflammation that is high because you have an autoimmune condition is a problem. Long-standing inflammation can damage the glycocalyx, and then that can lead to earlier cardiovascular disease. hsCRP, the lab that we talked about earlier, that's a good starting point to see how much inflammation is in the system. It's not the only lab, but it's a good starting point. Next question, can you actually lower blood pressure without medication? Absolutely. There are numerous lifestyle interventions. Exercise would be the first one. Eating a DASH type diet, the dietary approach to stop hypertension, has an effect at lowering blood pressure equivalent to one medication. Sunlight exposure, the UVA spectrum of sunlight will help lower blood pressure. There are various devices that help non-invasively lower blood pressure. The Respirate device, it's a breathing apparatus that helps lower blood pressure. The Zona Plus device looks like a joystick that you squeeze. Isometric exercises can help lower blood pressure. But blood pressure, I often tell people, is not a disease. It's an issue with something in your environment, and it's your job with your doctor to figure out what that root cause is and reverse that. All right, what are my thoughts on 11 minutes of cold water exposure and 57 minutes of sauna per week? Those are very specific numbers. I know about the 11 minutes of cold water theory. You can definitely do a lot more. I don't know why 57 minutes of sauna is exactly that. I usually recommend people do 3 to 4 sessions of sauna a week for 20 minutes of sweating at whatever temperature that requires. The benefit of sauna is that you are basically using infrared light to charge up the structured water in your cells, also known as the coherent domains. Cold water exposure helps activate brown fat, helps with energy flow in the mitochondria, and it does lower inflammation, amongst many things. So actually, right before this, I'd worked out this afternoon, took a shower, and then did probably 4 or 5 minutes of cold plunging, and I got out of the tub about 5 minutes before I jumped on this IG Live with you guys. So big fan of cold water exposure and sauna. Looks like 62-year-old woman with a lifetime heart rate of 85. What are my thoughts? So a normal heart rate is between 60 and 100. It's kind of a bell-shaped curve. There are people that are below 60 that are normal. There are people above 100 that are normal. But typically lower is better. It tends to mean you're more cardiovascular conditioned. You have better vagal tone. 85 would not be cause for any major concern, but would want to know how physically active you are, because if you're generally relatively physically active, your resting heart rate should be in the 60s. What to do to gently remove soft plaque without causing clots? What not to do? First thing is figure out what is damaging the arteries. Comprehensive blood work panel with Cleveland Heart Lab or Boston Heart usually will help start the process. You want to optimize nitric oxide pathways. You likely want to support the glycocalyx. You want to make sure that oxidative stress and inflammation on the biomarkers is as low as possible, and then use whatever tool possible to lower lipoproteins, generally ApoB under 70. If you have a lot of plaque, ApoB as low as 55 or below. What not to do, I would not do IV chelation, and I would not necessarily think about doing IV Plaquex. Can cholesterol in the blood circulation cause problems in other areas other than the heart? Yes, potentially. Depending on what your levels are, it can cause issues with your eyes, it can cause issues with your tendons, it can cause issues with gallstones. But the greatest majority is the ApoB containing particles causing atherosclerosis, aka plaque in your arteries. But it always starts with something disrupting the glycocalyx first. It's not the cholesterol's fault to begin with. It's the lipoproteins getting retained in the intima, causing vascular inflammation and plaque buildup. All right, I think we got through the pre-submitted questions, so I'll jump in there and start answering some of the comments. I saw some pop up. Somebody's asking, how do you get your LDL to 70 if it's at 99? That would be an LDL cholesterol. You want to first check your LDL particle number, or you could check your non-HDL total, which is a surrogate for LDL particles, or you could check ApoB. Any of those three is much better at predicting risk than just an LDL cholesterol. If you've already done the lifestyle interventions that you know how to do, then you're contemplating pharmaceuticals, it's statins, ezetimibe, PCSK9 inhibitors, or Nexletol. Those are the 4 classes of medications that have outcome data, meaning if you take these medicines, you have lower cardiovascular events, less heart attacks, strokes, stents, bypass, death, need for hospitalizations. But just having high cholesterol, I would not be as concerned. I'd want to know how much plaque you have in your arteries. So a CIMT, a calcium score, a clearly CT coronary angiogram, that would help guide how aggressive to be with your lipoproteins. I don't know what this says. What do you about Cavidex for artery plaque cleanup? I assume this means what do I know about it? I do know about the product. It's an Australian product. It has been having some issues with the FDA, which apparently as a week ago is starting to be resolved. It is interesting. It may have some effect on plaque regression. That is still being studied. If you want to know more about it, Dr. James Roberts probably has the largest cohort of patients who have used Cavidex to help reduce plaque and reduce symptoms. So potentially, do your own due diligence, but it is one that you have to work with somebody who understands what the risk benefits of Cavidex are. It only works either as an IV or a rectal suppository. There are no oral versions of Cavidex and will never be. Is a steam room as good as a sauna? The infrared heat would be, but the studies are generally done with the Finnish saunas. I personally, I've done many of the Turkish saunas and steam showers, but the concern is that, what type of water is being pumped into the room? Is it fluorinated water? Then now you're breathing in a bunch of fluoride or halides that could then disrupt your glycocalyx. It may affect your mitochondrial function. So not a huge fan unless you know exactly what kind of water is being pumped into the room of the steam showers. Thoughts on nose breathing? I heard it helps nitric oxide production. That is true. As the epithelial cells are stimulated, they may release nitric oxide. So I've been personally experimenting with mouth taping at night. My sleep scores tend to improve on my Oura Ring, and I've not had any issues doing the mouth tape. I was using some other vendor before. I now use MyoTape. MyoTape has a little slit through it. Makes it a little bit easier to breathe through your mouth if you had to breathe through your mouth, or if you want to get up and drink some water or something like that, you could do that, or if you had to talk. So it is beneficial, and humming is what actually somewhat activates it. So okay, what happens to someone following a cardioversion event for the first time? So a cardioversion is when the pads or stickers are placed on the chest, and the body's natural pacemaker, the sinus node, is basically reset. Cardioversions are most common when patients have supraventricular tachycardia or atrial fibrillation. Depends if the person is symptomatic or not. Depends on how fast the heart rate is, if it's an emergency or if it was an elective procedure. And depends on what their heart rates were before they needed this. Some patients have tachybrady syndrome, where they have episodes where the heart is going fast. They have episodes of the heart going slow. And when they're fast, the cardioversion happens to get them out of it. But now that they're out of the tachyarrhythmia, the fast rhythm, their heart rate is very slow, and they may need a backup pacemaker. So it does depend on what the underlying rhythm was, why they got cardioverted. I think I know who this person is, but it says it's their wife's question. Do all patients with atrial fibrillation require blood thinners? It depends on their risk of stroke. There's a calculator called the CHADS FAST calculator. It takes into account, do you have congestive heart failure, hypertension, what is your age, if you're a man or woman, are you diabetic, have you had a stroke, have you had a cardiovascular event, a heart attack, and if you had a previous stroke. You plug it into that CHADS FAST calculator, it gives you a score. The higher the score, you look at the algorithm, it tells you what is the yearly risk of having a stroke without anticoagulation. If your TRADS-VAS score is above 1, your risk is not insignificant, and unless patients have a significant bleeding issue, history of multiple gastric ulcers, some kind of colon issue that's bleeding that can't be cauterized, and getting blood transfusions, those patients should consider anticoagulation. The other people that should be careful is if they've had any type of history of any intracranial bleeding. Those patients often are ruled out as being candidates to resume anticoagulation. All right, and then one more question that popped up in the pre-submitted. Do I know anything about, okay, that's the Cavadex question. All right, I already answered that one. All right. What happens to our heart and circulation if we don't eat sugar for 3 months? I'll answer this question, but it's not likely to be something that you're ready to hear. Sugar is not the problem. It depends on how healthy your mitochondria are. What is your redox potential? Where do you live in the world? Is sugar appropriate? Is it seasonally appropriate? How much deuterium is in your diet otherwise? How much sun exposure do you have? All those things have a bigger effect. What is your blue light exposure? You could eat 0 sugar for 3 months, but if you're not protecting your eyes with blue blockers at night, the blue light enters your eyes, raises ACTH, raises cortisol, and your blood sugar goes high, irrespective of you eating carbohydrates. So it completely depends on many, many other factors. But that being said, answering the question, if you had issues with glucose before, you're likely not going to be insulin resistant if you really cut down on carbohydrates. High glucose spikes, high insulin spikes are significantly injurious to the glycocalyx. So it may be beneficial, but you have to look at all the other things, blue light exposure, stress management, sleep. Are you eating foods that are seasonally appropriate for your mitochondria? All right. I'll take a crack at this question, but this is not my area of expertise, heart rhythm issues anymore. I haven't been in the hospital for 5 years treating patients with acute atrial fibrillation. I've taken care of some patients with some chronic AFib, but I don't personally prescribe antiarrhythmic medications at this time. If rate controlling medications such as beta blockers or calcium channel blockers don't control their heart rate, and then they are having repeated episodes of AFib that are symptomatic and they can't tolerate the AV nodal blocking agents, then antiarrhythmics are considered. It does depend on the person's left ventricular function, depends on their left ventricular wall thickness. Do they have a stiff, thick heart? Do they have coronary artery disease? Then depends on what antiarrhythmics may be utilized in those individuals. Sometimes it's propafenone or dofetilide. Very rarely would amiodarone be used. There's too many complications with that medication. The antiarrhythmics tend to have more side effects than the beta blockers or calcium channel blockers, so that's why generally best used under the care of an electrophysiologist who can closely monitor the dosing. Some of the antiarrhythmics, including sotalol, they had to be brought into the hospital and be given the doses over 2 to 3 days and monitored on telemetry because they can be pro-rhythmic, so meaning they put you into a worse rhythm than AFib. So they are not to be messed around with. The ablations, usually are reserved for people who fail more conservative therapies, or they're just highly symptomatic when they're in AFib. Their quality of life is so impacted that an ablation is deemed worth the risk. There's risk of pulmonary vein stenosis. There's risk of damaging certain chambers in the heart. There's a risk of requiring a backup pacemaker if certain things are damaged. There are fatalities during AFib ablations, not common, but not zero. And the issue is many AFib ablations are not successful on their first attempt. I don't know the current stats, but when I was still in my training, it was told to me that most people would require the procedure at least 2 times in a 6-month period to have up to a 70% success rate of staying out of AFib. The ablation may help with quality, but there are some concerns still about what is residual stroke risk. So your stroke risk is still built into you, even if they get you out of AFib. So it would depend on the electrophysiologist if they would still recommend anticoagulation if you were on it before the ablation. All right. well, I think I got through all those questions as well. So I will obviously be back next Monday, 6 p.m. Central Time, and do it all over again. I have an email newsletter, which I have basically had on the back burner for probably the past year. I've not written out to it. Tomorrow morning, an email is going out to the whole newsletter list. I was involved with a heart attack and stroke prevention summit with Dr. Wolfson, the paleocardiologist. It's going to air at the end of February. I believe it's February 28th through March 2nd is the summit. The summit is free to join. I think there's probably some paid options if you want to like save the videos or you want to upgrade to certain other things, but the original, like when it's presented, will be free. So the email will come out tomorrow if you're interested in learning more about it. It's going to have information there. And then I'm going to try to be on a little bit more of a routine cadence of sending a newsletter out. So if you're not on my newsletter already, if you go to drtwyman.com, there is a link there to sign up for the newsletter. My YouTube channel will be housing this replay. It's drtwyman.tv, and I will start trying to do some more long-form videos and put them on the YouTube. I will do a video at some point in the near future about the Connect QT, or the Connect, yeah, it's Connect QT. I can tell you so far, I'm pretty impressed by it. It does have pretty good calibration with my Echo device in the office. So, you know, this device, I don't remember exactly what it is. I think it's probably about $225. Don't quote me exactly, but it was at least $200. But that's a fraction of the cost of the Echo device, which was north of $7,000. So this is probably going to be the gold standard for blood pressure at home in the near future. Still waiting for it's actually the Actia device to be released in the US. Once that's available, I'll start talking about that one as well. All right. And then I think, all right, one more question I'll answer that, then I'll jump off here and let you guys go for the night. So total calcium score of 133. Can't really read this number here. Can't read what that number is. It says something. Yeah, I can't read the number. It says something like R94, something. Should you be scared? No, calcium score 131 is intermediate risk. Calcium score over 400 is high risk. Calcium score over 1,000 is very high risk. Calcium scores over 1,000, you have over a 30% risk of having a heart attack in the next 10 years unless you do something about it. And the highest calcium score test I've ever seen is 7,770, to give you perspective. So if the calcium score test is concerning you, you need to talk to your doctor who ordered it so that helps you understand what caused the plaque in your arteries and what you can do about mitigating those risks. All right. Well, one more popped in. All right. Let's see if I can try to answer this one. I tried 5 HTP for brain health. Yeah, I'm not familiar too much of how to best dose that, so I'm going to turn that back over to your primary care doctor, whoever recommended 5 HTP. All right. All right, guys. Well, hope you guys have a great rest of the evening. I'll see you guys next week. And if you're not on my email list, just go to my website, drtwyman.com, and sign up, and you'll get the email tomorrow. Take care.